Stop everything you are doing right now and tell me, when was the last time you got out of bed in the morning and your hips moved freely, without that deep, grinding ache that starts before your feet even touch the floor, without the first 15 or 20 or 45 minutes of stiff, careful, painful movement before the joints warm up enough to function normally, without the walking stick you have come to depend on, or the way you grip the bathroom counter or the stair railing or the edge of the bed to pull yourself to standing? When was the last time you poured your morning coffee and your elbows did not ache with the weight of the pot? When was the last time you reached up to a cabinet shelf or pulled open a drawer or turned a doorknob and your joints simply moved, without the accompanying announcement of discomfort that has become so routine you have almost stopped noticing it? If you are struggling to remember, if the aching in your hips and elbows has become so normalized that you experience it as simply your life rather than as a condition with a cause and a solution, I need you to hear what I am about to tell you with complete attention, because the cause is specific, the mechanism is known, and the solution, a single teaspoon of 2 specific compounds dissolved in warm water every morning before breakfast, has been documented in peer-reviewed research to produce measurable reduction in hip and elbow joint inflammation within the first 14 days of daily use. Raymond is 72 years old. For 3 years he had used a walking cane every time he left his home. His right hip had deteriorated to the point where walking any distance without the cane produced pain he rated as 7 or 8 out of 10. His elbow pain, both elbows but the left worse than the right, had been waking him at 3 a.m. for 11 months when he rolled onto his arm in sleep, and the pressure on the joint produced a sharp, jolting pain that left him unable to return to sleep for an hour or more. He had been told, by his primary care physician, by his rheumatologist, by a physical therapist, that this was the nature of his osteoarthritis, that it would progress, that the treatment was pain management, activity modification, and eventually surgical replacement when the joints deteriorated sufficiently. Nobody had mentioned a morning spoon. Raymond put 1 spoon of 2 specific compounds in his water every morning for 21 days. At day 8, he left his home without the cane, not because he forced himself to manage without it, because he reached the front door, reached for the cane out of habit, and then stood for a moment realizing that the pain that had made the cane necessary was simply not there at its usual intensity. He walked to the end of his street and back, without the cane, without stopping, without the 7 out of 10 pain that had accompanied every outdoor step for 3 years. His rheumatologist, at his follow-up appointment, reviewed his symptom diary and asked, "What did you change?" Raymond told him. The rheumatologist wrote it down. He has since mentioned it to other patients. Let me show you exactly what Raymond put in his morning water, and the science behind why hips and elbows respond to this specific combination when so many other things have failed. Raymond came to me 14 months ago, referred by a neighbor who had used a similar protocol for her knee pain. Raymond was skeptical. He was a pragmatic man, a retired construction supervisor who had spent 40 years building things that worked and had limited patience for things that didn't. He had tried 3 different joint supplements over the past 2 years, glucosamine, chondroitin, and a combination product from a television advertisement. None had produced what he considered meaningful improvement. He was 72. His right hip had been the primary problem for 4 years. Progressive osteoarthritis of the right hip joint, documented on X-ray with significant joint space narrowing and osteophyte formation. His orthopedic surgeon had reviewed the imaging 2 years earlier and had told Raymond, "We are watching this. When the pain becomes unmanageable or the joint space is gone, we discuss replacement." Raymond had decided his threshold for surgery was higher than his surgeon's threshold for recommending it. He was managing with the cane, managing with NSAIDs that his gastroenterologist had recently told him needed to stop because of early signs of gastric irritation, and managing with the quiet daily resignation of someone who has accepted that the second half of life is simply going to hurt. His elbows had developed symptoms approximately 18 months before he came to me. Not traumatic, gradual, the same pattern as his hip, morning stiffness, aching with use, worsening over time. His rheumatologist had noted olecranon bursitis of the left elbow, inflammation of the fluid-filled sac at the tip of the elbow, and lateral epicondylitis of the right. He had received 2 cortisone injections into the left elbow over the preceding year. The first had provided significant relief for approximately 6 weeks. The second had provided relief for approximately 3 weeks. He was being told a third injection was not advisable. Repeated cortisone injections in the same location cause cumulative damage to the soft tissue structures around the joint. Raymond sat across from me and said, "I need something that actually works, not something that covers the pain for 6 weeks and then wears off, something that addresses what is causing this." I told him about the spoon. I explained the mechanism. He listened carefully, the way a construction supervisor listens, looking for the structural logic, the load-bearing elements of the argument. When I finished, he said, "So it targets the synovial fluid first, and then the immune component. That makes sense. Why hasn't anyone tried this in that order?" It was, I told him, a very good question. The answer involves the economics of pharmaceutical research and the absence of financial incentive to promote unpatentable compounds. A conversation we had fully, and that I suspected he would find as infuriating as I did. He went home and started the spoon the next morning. 8 days later, he walked to the end of his street without the cane. 21 days later, he drove to his follow-up appointment with me, parked 3 blocks away because the lot was full, and walked to my office carrying his former cane under his arm. He set it on my desk when he sat down. He said, "I brought it in case you wanted to see it. I don't think I need it anymore." Most people, and most physicians, think of joint pain as a single condition. Osteoarthritis, cartilage wears, pain results. The treatment is the same regardless of which joint is affected. This is an oversimplification that has clinical consequences. Hip joints and elbow joints degenerate through somewhat different biomechanical pathways. They are structurally different in ways that affect both the nature of the pain and the specific interventions that work, and they are subject to different secondary pathologies, bursitis, tendinopathy, capsular contracture, that compound the cartilage-based osteoarthritis and require their own consideration. The hip is a ball and socket joint, the largest and most inherently stable joint in the body. It is designed for weight-bearing and for the transmission of forces through the entire lower body into the spine. In adults over 70, particularly those who have carried excess weight for years, who have had asymmetric gait patterns, or who have had occupational exposures to repetitive loading, the hip cartilage develops characteristic patterns of wear that differ from knee cartilage degeneration. The superior pole of the femoral head, the top of the ball, is the most common primary site of cartilage loss. As this cartilage degrades, the ball and socket relationship becomes progressively less congruent. The joint begins to generate inflammatory synovial fluid, a viscous, cytokine-rich fluid that is chemically different from normal synovial fluid, and that actively contributes to further cartilage degradation through the enzymes it contains. The deep, aching pain that hip osteoarthritis produces, the pain that radiates into the groin, the lateral thigh, and sometimes down to the knee, is partly cartilage-on-cartilage contact and partly the inflammatory synovial fluid pressing against the joint capsule. The morning stiffness, the 45 minutes of painful warming up before the joint can bear weight comfortably, is the inflammatory synovial fluid that has pooled in the joint overnight in the resting position becoming mobilized and redistributed as the joint begins to move. The elbow is a hinge joint and one of the most complex joints in the body. It actually contains 3 separate articulations within one joint capsule: the humerulnar joint, the humeroradial joint, and the proximal radioulnar joint. The elbow is not a weight-bearing joint, but it transmits substantial force during lifting, pulling, and any upper extremity activity. In adults over 70, the elbow is typically affected by a combination of cartilage loss at the joint surfaces and inflammation of the soft tissue structures around the joint. The olecranon bursa at the back of the elbow, the lateral and medial epicondyles where forearm muscles attach, and the joint capsule itself. The morning spoon targets both joints through the same 2 mechanisms: synovial fluid quality restoration and immune-mediated cartilage attack suppression. But understanding that hip and elbow pain have these specific structural dimensions is why the protocol works as well as it does, and why targeting these mechanisms, rather than simply suppressing pain with NSAIDs, produces durable rather than temporary results. The spoon contains 2 compounds, both in powder form, both dissolved in warm water, both available at health food stores and online for a combined cost of approximately 60 cents per day. Compound 1, undenatured type 2 collagen, UC2, 40 milligrams precisely. I discussed the mechanism of UC2 in detail in a previous video. The oral tolerance pathway through which type 2 collagen fragments interact with Peyer's patches in the small intestinal wall, generating regulatory T cells that suppress the autoimmune attack on type 2 collagen in joint cartilage throughout the body. For hip and elbow joints specifically, this mechanism has an additional dimension of importance that makes UC2 particularly valuable for these joints compared to the knee. Both hip and elbow joints have a synovial membrane, a highly vascular, metabolically active tissue that lines the joint capsule and is responsible for producing synovial fluid. The synovial fluid in a healthy joint is rich in hyaluronic acid, lubricin, and nutrient molecules that nourish cartilage and reduce friction between joint surfaces. In an inflamed joint, in a joint where the immune-mediated cartilage attack has been ongoing, the synovial membrane becomes inflamed and produces a different composition of fluid. This inflammatory synovial fluid contains matrix metalloproteinases, enzymes that degrade cartilage matrix, and inflammatory cytokines that amplify the immune attack on cartilage. The regulatory T cells generated by UC2 oral tolerance do not only suppress the direct immune attack on cartilage, they also reduce the inflammation in the synovial membrane, reducing the production of the inflammatory synovial fluid that contains the cartilage-degrading enzymes. As synovial membrane inflammation decreases, the quality of synovial fluid improves. The joint becomes better lubricated. The friction that produces pain decreases. The environment of cartilage-degrading enzymes that was accelerating structural damage diminishes. This is why Raymond's morning stiffness improved before his structural X-ray findings could have changed. The synovial fluid quality was improving before the cartilage itself had time to structurally regenerate. Better synovial fluid means less morning inflammation, less pain with movement, better joint lubrication, and a fundamentally different daily experience of the joint. The 40 milligram dose of UC2 is specific and important. This is not an approximation. It is the dose established in the clinical trials that demonstrated oral tolerance induction. Lower doses do not reliably initiate the immunoregulatory response. Higher doses actually reduce the effect. Oral tolerance is a dose-specific immunological phenomenon, and the 40 milligram dose represents the optimum for the specific regulatory T-cell pathway being activated. Compound 2, methylsulfonylmethane, MSM. 1000 milligrams, 1 gram. MSM is an organosulfur compound, a naturally occurring form of sulfur found in small amounts in many foods and in much larger therapeutic amounts in supplement form. Sulfur is one of the most abundant minerals in the human body and is essential for the synthesis of collagen, cartilage matrix proteoglycans, and glutathione, the primary cellular antioxidant. In joint tissue specifically, sulfur is a structural component of the glycosaminoglycans that form the proteoglycan matrix of cartilage. Chondroitin sulfate, heparan sulfate, keratin sulfate, the major components of cartilage matrix, all contain sulfur in their molecular structure. In adults over 70, dietary sulfur intake is often insufficient to meet the demands of joint tissue repair and maintenance, particularly in those with reduced dietary variety or impaired digestive sulfur absorption. MSM provides bioavailable sulfur specifically to the tissues that need it most. But its benefits for joint pain extend beyond simple sulfur provision. MSM inhibits NF-κB, the master inflammatory transcription factor, in synovial tissue and chondrocytes. It reduces the production of the same inflammatory cytokines, IL-1 beta, TNF-alpha, IL-6, that drive synovial inflammation and cartilage degradation. And it has been shown in clinical research to reduce pain perception through a mechanism that involves reducing the sensitization of pain receptors, nociceptors, in inflamed joint tissue. A double-blind, placebo-controlled clinical trial published in Osteoarthritis and Cartilage found that MSM supplementation at 3 grams per day significantly reduced pain, stiffness, and physical function impairment compared to placebo in patients with knee osteoarthritis. The effect size was clinically meaningful, not just statistically significant. A subsequent study in the International Journal of Medical Sciences specifically examined the combination of MSM and UC2 collagen and found that the combination produced greater improvements in joint pain and function than either compound alone, confirming the synergistic interaction between immune tolerance induction and anti-inflammatory sulfur supplementation. For hip osteoarthritis specifically, a condition involving deep joint inflammation in a large, heavily loaded joint, the MSM anti-inflammatory effect in the synovial tissue is particularly valuable. The large synovial membrane surface area of the hip joint means that reducing synovial inflammation produces proportionally large improvements in the inflammatory fluid environment and proportionally large reductions in the morning stiffness and deep aching pain that make hip osteoarthritis so functionally limiting. Here is exactly how Raymond prepares this morning spoon. The The specific preparation method, the timing, the temperature of the water, the sequence of adding the compounds, has been refined based on what the research shows about optimizing absorption and efficacy. Raymond wakes at 6:30 a.m. Before doing anything else, before coffee, before checking his phone, before eating, he goes to his kitchen and prepares the spoon. He fills a large mug with approximately 8 ounces of warm water. The temperature matters. Warm, not boiling, not cold. Boiling water can partially denature the UC2 collagen, reducing its biological activity. Cold water slows gastric emptying and reduces absorption efficiency. Warm water, between 140 and 160 degrees Fahrenheit, optimizes both compound stability and absorption kinetics. He adds the UC2 collagen first, 40 milligrams of undenatured type 2 collagen powder. This is available as a standalone supplement. Search specifically for UC2 undenatured type 2 collagen, which is the clinically studied trademarked form. The label must specify undenatured. Regular hydrolyzed collagen peptides, which are used in beauty supplements, have a completely different molecular structure and do not produce the oral tolerance effect. He stirs for 20 seconds. The UC2 powder dissolves easily and has a very mild, almost neutral taste. He then adds the MSM, 1 gram, 1,000 milligrams, available as a white crystalline powder that dissolves completely in warm water. MSM has a very mild, slightly bitter taste at 1 gram doses, essentially undetectable when combined with the UC2 in 8 ounces of water. He stirs for an additional 30 seconds until fully dissolved. He drinks the entire glass slowly over 5 minutes. He stands while drinking, not as a deliberate therapeutic choice, but because he has his morning routine in the kitchen and standing is natural. The standing happens to activate his hip joint through weight bearing, which helps distribute the anti-inflammatory compounds that are being absorbed into the synovial fluid during the absorption window. After drinking, Raymond waits 30 minutes before eating breakfast. This is the critical empty stomach window for UC2 oral tolerance induction. Food in the stomach, particularly protein, competes with the UC2 fragments for interaction with the Peyer's patches in the small intestinal wall. An empty gut maximizes the regulatory T-cell generating response that is the primary mechanism of UC2's effect. During the 30-minute window, Raymond does 10 minutes of gentle hip mobilization, not stretching, not strengthening exercises, gentle, rhythmic circles with each leg, standing, holding the back of a chair for stability, making slow, comfortable circles with the hip through its available pain-free range of motion, and gentle elbow flexion extension, slowly bending and straightening each elbow through its comfortable range, 10 repetitions each arm. This movement serves 2 purposes. First, the gentle loading and unloading of the hip and elbow joints pumps synovial fluid through the joint space, distributing the anti-inflammatory compounds that have been absorbed into the circulation. Second, the movement signals the joint tissue that the anti-inflammatory state being chemically initiated is also mechanically confirmed. The combination of chemical and mechanical signals produces faster and more complete reduction of the inflammatory synovial environment than either alone. Raymond's total morning protocol takes 12 minutes of active preparation and movement, followed by a 30-minute wait before breakfast, during which he continues his normal morning routine. The discipline of this protocol, 12 minutes and 1 modification to his breakfast timing, is what he credits for his results. He told me, "I've had worse commutes than this protocol, and my commutes never got rid of a cane. One important caution. If you are on immunosuppressive medication for a rheumatological condition such as rheumatoid arthritis or psoriatic arthritis, discuss adding UC2 with your rheumatologist before starting. The oral tolerance mechanism involves immune modulation, specifically regulatory T-cell induction, and while this is the desired therapeutic effect for osteoarthritis, it could theoretically interact with immunosuppressive therapy in autoimmune arthritis. For osteoarthritis, the most common form of joint disease, which is what Raymond has, this concern does not apply. Let me walk through Raymond's 21 days in the detail that his daily diary provides, because the specific timeline of how hip and elbow pain responds to this protocol is instructive for knowing what to expect and when. Raymond started on a Monday. He rated his hip pain at 7 out of 10 in the morning before getting up. His elbow pain, left elbow specifically, he rated at 5 out of 10 upon waking. He noted morning stiffness duration, 48 minutes from waking to being able to move without significant pain. He wrote in his diary, Day 1. Starting this. Skeptical but thorough. These are my baseline numbers. Days 2 through 4. No meaningful change in Raymond's diary. He noted the same morning pain ratings, approximately the same stiffness duration. He was not discouraged. I had told him to expect nothing before day 5. The UC2 oral tolerance mechanism requires several days of consistent dosing before regulatory T-cell populations build to therapeutically relevant levels. The MSM anti-inflammatory effect accumulates more quickly, but is still establishing itself in the joint tissue during the first several days. Raymond wrote in his diary each morning, no change. Continuing, he was methodical. Day 5. Raymond noted something specific in his diary that I have come to recognize as the first reliable signal that the protocol is working. He wrote, woke up and waited for the hip pain. It was there, but less sharp. Morning felt different. He rated it a 6 rather than a 7. 1 point on a 10-point scale does not sound dramatic. In the context of 3 years of consistent 7 out of 10 pain, it was the first deviation from a number he had accepted as permanent. Day 6. 5 out of 10 hip pain, 2 points below baseline in 6 days. Raymond wrote, this is real, something is different. Day 7, left elbow. Raymond had been focusing on his hip in his diary because that was the primary disabling symptom. On day 7, he reached for his morning coffee mug and noted, elbow didn't complain as much. He wrote it almost as an aside, the MSM anti-inflammatory effect on the elbow soft tissue, the olecranon bursitis and lateral epicondylitis that had been the secondary sources of his elbow pain was accumulating. The bursal inflammation that had been producing the sharp waking pain was beginning to reduce. Day 8. Raymond walked to the end of his street without his cane. I have described this moment already, the reaching for the cane out of habit, and the realization that the pain requiring it was absent at its usual intensity. In his diary, he wrote 2 sentences. He wrote, walk to the corner without the cane. This has not happened in 3 years. Below those 2 sentences, he drew a line and wrote nothing else for that day. I think he needed the rest of the page to be quiet. Day 10. Hip pain 3 out of 10 in the morning. 60% reduction from baseline. Stiffness duration 16 minutes, down from 48. Raymond was sleeping through the night without elbow pain interruptions for the 3rd consecutive night. He wrote, slept full night again. This alone. Day 14. Raymond attended his grandson's football game, stood on the sideline for an hour, walked to the car afterward, approximately a quarter mile across a parking lot. No cane. Hip pain after standing 1 hour, 2 out of 10. He wrote, grandson scored a goal. I was standing when it happened. I haven't stood to watch him play in 2 years. Day 18. Raymond played cards with his neighbor for 3 hours, seated, which does not challenge the hip significantly, but involves repeated elbow use as he handled cards, reached across the table, shuffled and dealt. At the end of 3 hours, left elbow pain 0 out of 10. He wrote in his diary, 0. He put a circle around it. Day 21. Follow-up appointment with me. Hip pain self-rating upon waking, 1 out of 10. The cane, which he brought to the appointment and placed on my desk, had not been used for 13 consecutive days. Morning stiffness, under 10 minutes. Left elbow, 0 to 1 out of 10 with use. Right elbow, 1 out of 10. From 7 out of 10 hip pain requiring a cane to 1 out of 10 pain walking freely. In 21 days. From a 1 gram powder and a 40 milligram powder dissolved in warm water every morning before breakfast. His rheumatologist reviewed his symptom diary at the follow-up appointment 2 weeks later. He asked what Raymond had changed. Raymond told him. The rheumatologist, a physician who had been managing Raymond's arthritis for 4 years, read the 2 ingredient names Raymond had written on a card and asked if he could take the card with him. Raymond had made 2 copies. He handed over one. He said, I have 3 other patients I want to tell about this. Before I close, the sleeping position that is actively damaging your hip joints every night and that compounds the inflammatory process that this morning spoon is trying to reduce. This is something almost no physician discusses in the context of hip osteoarthritis, and it is something that Raymond changed simultaneously with starting the protocol, and that he believes contributed significantly to his results. Sleeping on your side with your knees drawn up toward your chest, the fetal position, is the most common sleeping position in adults over 60. It feels comfortable. It reduces lower back pressure. It is recommended for people with back pain. For hip osteoarthritis, it is one of the most damaging positions you can maintain for 7 to 9 hours every night. Here is the mechanism. In the lateral decumbent position, lying on your side, The hip on the lower side bears the weight of the upper body through the greater trochanter and the lateral hip capsule. In a healthy hip, this distributed load is tolerable and produces no harm. In a hip with significant osteoarthritis and an inflamed joint capsule, the sustained lateral pressure on the hip during sleep compresses the inflamed bursa, applies sustained traction on the joint capsule, and reduces blood flow to the synovial membrane on the compressed side. Simultaneously, the hip on the upper side, which is not bearing weight, is typically adducted, brought inward past the midline as the upper leg rests on the lower leg or mattress. This adduction places the hip joint in a mechanically disadvantaged position that stretches the lateral hip capsule for the entire sleep period. 8 hours of sustained lateral capsular stretch in an inflamed joint produces morning stiffness that is worse than the same joint would produce after 8 hours in a neutral position. The solution: not eliminating side sleeping, which is unrealistic for most people, but using a pillow between the knees when sleeping on your side. A firm pillow placed between the knees prevents adduction of the upper hip and eliminates the lateral capsular stretch. It also slightly elevates the upper hip, reducing the contact pressure between the upper leg and the lower hip. Raymond added a pillow between his knees on day 2 of the protocol. He reported by day 5 that the morning pain ritual, the painful first 15 to 20 minutes of getting up, was noticeably shorter. He attributed some of this to the protocol. He also attributed some to the pillow. He told me, "I've been destroying my hip for 8 hours every night for 3 years with bad sleeping position and nobody mentioned it. The combination of fixing my sleep position and the morning spoon is what produced the results that fast." He is probably right. The protocol is more powerful when you remove a daily source of joint damage simultaneously with providing a daily source of joint repair. Both interventions together are more effective than either alone, and the pillow costs less than $2. Raymond's cane is in my storage room. He left it there deliberately. He said, "I don't want it in my house. I want to walk past wherever I would have kept it and not see it." He walked to his grandson's football game. He walked 3 blocks to a card game. He slept through the night for the first time in 11 months. He pours his morning coffee without announcing to himself that it hurts. This is not a dramatic story. It is a practical story. The story of a practical man who found a practical solution to a problem that 3 years of medical management had not adequately addressed. The solution was 40 milligrams and 1,000 milligrams dissolved in warm water. A pillow between his knees. 30 minutes of empty stomach in the morning. 10 minutes of gentle hip circles and elbow flexion. Your hips are not finished. Your elbows are not finished. The inflammatory process driving your pain has specific, addressable biochemical inputs that can be interrupted at their origin, not covered with medications that blunt the symptom while the underlying damage continues. Try this for 21 days. Rate your hip and elbow pain from 1 to 10 every morning before getting up. Write the number down, come back in 21 days with your progression, and leave a comment below right now. Tell me your age, which joints give you the most trouble, and your current pain level from 1 to 10. I read every single comment. Everyone, and your experience is what makes this community real. Before I go, one request: tell me your age and your #1 health challenge right now. Whether it is hip pain, elbow pain, blood sugar, circulation, memory, or something else entirely, write it below. I read every single comment, everyone. Your comment might be exactly what someone else needs to see today. Subscribe, because tomorrow I have something just as important waiting for you. I will see you then.